All right, welcome everybody to the Board of Health today. We'll go ahead and call the meeting to order here today. I want to be respectful of everybody's time. So welcome to the October meeting of the Board of Health District. We'll go ahead and begin with doing the roll call. So Ben Wake, City of Spokane Valley.
Kate Burke or Councillor Troy from the City of Spokane.
Michelle Fossum, Legal Counsel.
Karen Stratton, City of Spokane.
Andrea Frostad.
Chuck Hafner.
Linda Thompson, City of Spokane Valley.
Josh Kern, Spokane County.
Bob Lutz, County Health Officer.
Amelia Clark, Administrative Officer.
All right, welcome and thank you everybody for being here. Next on our agenda is citizen input. Oh, we have one citizen for input today. We are allowed 3 minutes to speak before the board. And so if we can have Jackie Gallion come on up. And our Councillor Troy will be doing our 3-minute countdown today.
Hello, Jacqueline Gallion, City of Spokane Valley. I would like to remind the board that we, the stakeholders, have been requesting a roundtable and agenda status for almost 3 years with no action or response from Spokane Regional Health District. I am appalled at the continuing attack on non-medical and religious exemptions all over the country, and at the gross misrepresentation of facts being used to falsely justify these attacks. From exaggerating the historical danger of measles and chickenpox to pretending that vaccines are harmless, to trying to invalidate that there is any legitimate reason to object to any vaccine for any reason, your narrative is simply pharma talking points. The biggest fraud is the idea that the only reason parents are exempting is because there are exemptions, and if you eliminate them, we will all just cheerfully roll up our sleeves and comply. No, we will not. We will leave the schools or this state. Pharma lobbyists told legislators in New York to ignore their constitution and parents. They also told them that Californians' exemption law kicked everybody out all at once. And things are great, which is not true. All students were grandfathered for an entire year. Then when it kicked in, it grandfathered all high school students through graduation, all 1st and 6th grade, and only kindergarten and 7th graders were impacted. When students hit the checkpoints, they are leaving the schools, and enrollment is down every single year. New York believed the pharma lies, ended exemptions, and there are thousands of parents protesting and fighting for the rights of their children. Just like what happened here when kids were kicked out for the Marshallese mumps outbreak, a middle school student in New York has died of suicide. Don't you people talk to each other? Now there is complaining that the religious exemption for MMR is going up. Of course it is. You eliminated the other categories. If you think you can just get a medical exemption, you are sorely mistaken. In California, an investigative team contacted over 800 pediatric practices, and all of them said they don't write medical exemptions. Not that they examine patients and deny them, that they, as a policy, will not write them under any circumstances. That is why the doctors who will write a medical exemption write most of them. These compassionate doctors are being accused of monetizing their medical degree because they charge a standard appointment fee for a time to review records. But with the right coding, and vaccinating pediatrician can be reimbursed $300 for an administration fee for labor for the injections done, on top of the office appointment, at the 2-month well baby check. $300 for 5 injections in 5 minutes. Who is really monetizing their license? I truly hope you are paying attention to all the manipulation of the facts to support the agenda that no one, child or adult, should be allowed the full, unrestricted right to refuse any liability-free, for-profit vaccine, medication, or procedure for any reason they want. Thank you.
Thank you. Next, going to the consent agenda. Is there anything on the consent agenda that a member would like to set aside for individual consideration? Seeing none, do I have a motion to approve the consent agenda?
I'll make a motion.
And I'll second it.
All right. All those in favor, please signify by saying aye.
Aye.
All those opposed, same sign. Consent agenda is approved. Now moving on to action items Number 1 is the Resolution 1905 adopting the 2020 Health District fee schedule.
Hi.
Mr. Riley?
As you can see, there's 3 resolutions on the table today. 2 of them we're hoping to get a vote on. The third one is going to be the first touch on the budget one. But starting on Resolution 1905, adopting the fee schedule, it's sort of followed the same policy that we've had the last few years. There was no changes to the policy, so all the divisions submitted their fees into finance a month ago or so. We went over those as we developed the 2020 budget. And though there's not a whole lot of changes in there, there was a few necessary changes that went on. But other than that, a lot of it was status quo from the current year and keeping that same moving forward. So I'm hoping that you support. And I did take it to both the Budget and Finance Committee and to the Executive Committee, who recommended bringing it forward to the board.
Any discussion on the fee schedule? Any questions on the fee schedule?
I make a motion that we adopt the resolution 19-05 regarding the fee schedule, fee policies that we have.
Okay.
Second.
Any further discussion? Seeing none, all those in favor, please signify by saying aye.
Aye.
All those opposed, same sign. Fee schedule is adopted.
All right, thank you. Resolution 19-06 is authorizing a 2019 general fund balance amendment. And what I did prepare for you, it's in your packet today, and then on the display up there, is the year-to-date through September for 2019, based upon our budget as it currently is, and where we're at. I presented that to you both by the whole agency expense and revenues, and then you also have one that says the divisions by expenses and revenues. And as we analyzed that, we realized that with the school district program in CFS, that we weren't going to have enough budget authority, not only as a division, but also as the whole agency, for what we got approved for at the start of the year. And so we are asking for the resolution 1905 to be a budget amendment increase. And we are asking for the overall increase to go up $2.7 million in expenses, as we're pulling in some more money and going to save some of the reserve dollars that we were going to use at the original budget. So this is a revised budget, hopefully necessary to complete this year.
Questions?
So I move that we adopt Resolution 1906, authorizing a 2019 general fund budget amendment.
Second.
All right, thank you. Any other questions or
I
discussion?
would make some comments that the Budget
Okay.
Committee has met on numerous occasions, and so that the information that the board is receiving has been pre-approved by the Finance Committee. And so if there are any questions, why, you can certainly ask me. I guess am I the only one here? And that's there.
I'm on there.
And 2 of us. So, but nevertheless, it has been approved, pre-approved, and we've analyzed the situation and feel that it's appropriate at this time to move forward with it.
Okay. Wow, talkative group today here, so I guess that means we're ready for the question. All those in favor, please signify by saying aye.
Aye.
All those opposed, same sign. Budget amendment is approved.
All right, and the final resolution that we're not asking for a vote on today, this is the first reading of that, is our 2020 SRHD budget. And as you can see, it's increased up to the $39,210,125 is the asking expenses. And then our revenues are coming in where it is going to need the $703,000 out of our reserve balance, where we just had lowered that down to $291 from the current year. And this was worked on all summer long by the program managers, moving up to their division directors, moving on to finance, and then the joy as Amelia came on board as our director, she pretty much spent the first 2 weeks in budget meetings with divisions and programs and going over all of the quick learn on the budget, and she did a great job asking some great questions, and so we are looking for, again, I took it to both the Budget and Finance Committee and to the Exec Committee of the Board that brought it forward for this first reading for you to have, and feel free to answer questions now or as the month goes along or in the next couple of weeks before we bring it back at the December 5th meeting for approval.
Mike, on the 2019 year-to-date, where a capital outlay, where we've expended 168%, does that need some explanation, rationale for that? And also, if you look down below that small chart, we look at one that's 190 at rents and so forth, private foundation, and that one.
Let me go back to my
Please.
year-to-date. So on the, which were you asking about on the, okay, the capital outlay. Capital outlay, what had happened was we had an anticipation, most of that is leasehold improvements. So those are improvements to our building. As we had renters leave and we took over areas and got new grants in, we had to do some more remodeling to be able to fit the staff, because our staff is growing and being up to those levels. And so the capital outlay was just that we had decided to complete some of those projects in this year, so we didn't have to carry them into next year, and still try to keep overall within the budget with things like supplies and services being down. So it was decisions by the management to complete some of those projects currently. And then the other one you're asking about was the rents, interest, and private foundation. We just got some extra private foundation money in. Dr. Lutz went and found some of the foundations to give some money for his opioid treatment work, and they were unanticipated at the budget time. If we know about the budget amount that we're going to get from foundations at the time of the budget, we put them in there. But as the year went along, there's other ones we apply for and we get in, and so we just were able to get in more foundation money from various groups.
Thank you.
You're welcome.
So was some of that, because that's rents and things of that nature also, did some of that additional revenue then offset the additional expenses? Or those categories don't really match up?
No, they do. No, I guarantee you. If we got some money in, there was certain work to be done with that. And so, such as my example on the opioid work that Dr. Lutz did, he had a community meeting and a provider meeting out in the community that was, some of this money was paid for those events.
Other questions? So one thing that I wanted to kind of highlight when I was at the Finance Committee, we actually, as we looked at the budget, it wasn't very clear of how much we were pulling from the end fund balance. And so there's actually a separate line on the 2020 resolution this year that talks about, if I find it here, the use of reserve funds. And so we actually pulled that out so that way it's identified of how much money is actually being pulled from the reserve fund. So I don't, a little less ambiguous, because in the past years we did pull from the reserve funds, but it was kind of buried between the lines.
Correct.
So just kind of wanted to highlight that, just in case anybody saw that on there. Okay, any other questions? No? Comments? I know you were at the Finance Committee also. Did you have anything else you wanted to add for the 2020 budget? No?
I don't think so.
Okay.
Okay, and I don't know that the Budget and Finance Committee is planning to meet again, but I definitely will bring it by the Exec Committee of the Board the week before, or a couple weeks before the December 5th meeting. So, thank you.
So this is on our agenda for action today. Do we need a motion to move it from first reading to second reading? No? Okay. Sounds good.
All right, thank you.
Thank you. So for reports, I don't know if Brian had anything for his report as chair. So we'll go ahead and skip that. You can, when he gets here, you can add anything in there that we may have missed. The Board of Health committees, I think we've gotten a lot from the Finance Committee already. Is there anything else that you want to add from the Finance Committee? Shaking their head no. That's good. Education communication, I don't think they met this month.
We have not met, but we will plan to meet after the policy committee has met.
Okay. And policy committee, I think you guys have met, but I think isn't that coming up further on our agenda when we get to legislative? Is there anything other than that, or do you want to provide something in your report now?
We can just wait for the legislative update.
Okay. I think that covers all of our committees. Administrative officer.
Going much faster this time. All right. So this is my second board meeting since taking my role as the administrative officer here at the Health District. And one thing that I really thought this might be a good opportunity to do is to just talk about some of my initial observations that I've made since coming into the role and what I think that means for my work plan after I kind of get through this first 6 months of time spent observing and learning. So as some of you know, because I've met with you, I've been reaching out to Board of Health members as well as members of the executive leadership team, and I'm starting to work my way through all the managers of the organization, spending time at programmatic meetings. And one thing that has kind of come up as a theme repeatedly through these discussions is really being able to talk about the impact that the health district has really throughout the district and not just in Spokane proper. And so I wanted to take a minute to highlight some of the wonderful staff that we have here and talk about some of the numbers and what that means for the overall district. How that relates to my work plan is I definitely think going forward for 2020, especially since that's our 50th year, the health district started in 1970, but that we need to start maybe thinking about an annual report that really talks about our impact. So just one really great program highlight. We have had some great news coverage recently. And here is Joel, one of our steady, he's currently moving into a different position, but works on helping prevent falls and working with, sorry, my button's off here, providers in the community and throughout the area on what they can do to help prevent falls throughout the area. And you can see from some of the coverage, Spokane County has a high number of people who actually fall and has a death rate, a higher number of people die from accidental falls. In the violence, I won't go into that a lot because I know Dr. Lutz is going to really go into that during his presentation. But if you had a chance to see that video, I know we talked about it here at the board meeting last month. The health district helped supply a lot of the data that was used in pulling together the In the Violence video. Staff were actually interviewed during that. Our nurse-family partnership plays a huge upstream approach, and when I say upstream, I mean that they're getting in and working with families earlier than sometimes it's not until you know that abuse is happening to where nurse family partnership is really in a place where they can get in and work with families earlier and get them off on the right foot for family development. Nurse Family Partnership, which we actually just received another expansion grant, so kudos to Sheila and the team in Community and Family Services. But currently, our Nurse Family Partnership program serves 180 families. 134 of those clients do reside in the city of Spokane, but 35 clients, or 20%, actually live in the valley Spokane Valley, and then the other 6% are made up of families who live outside of those two areas. So it's really a great program for getting out throughout the whole county and not just the city. One of our most recent activities is free vaccination clinics for kids going back to school. Due to, I'm new in town, so due to what I'm told is an unseasonably early snow day, there was school canceled on the day that we were supposed to have one at Lidgerwood. But, we were able to do, over 400 vaccines, both in the Valley and at Meade, for children and adults who were in need of vaccines. One really great program that gets throughout the whole region related to services is the Infant Toddler Network. And if you're not familiar with that, the Infant Toddler Network is a way to identify toddlers and other, young children who are, well, I think in this case, under 3 years of age, but who are potentially on the road to having some type of cognitive, physical, maybe language disability that they're going to need additional assistance as they start entering school. And I won't go through and read every single place where we work with families, but as you can see, we've got a great number of children from all around the area, and the numbers, as you can imagine, align where we have, the bigger school system. So Spokane Public Schools, District 81 has 505 children, Central Valley 207, Meade 112, and then you can kind of see where the others are peppered through there. So I wanted to keep my part of my presentation short because I know that Dr. Lutz is going to come up and talk with more staff about nurse-family partnership and ending the violence. But in terms of my upcoming focus, I'm going to continue having introductory meetings with Board of Health members, continuing my meetings with managers and ELT. One thing I'm really starting to do this month, I've already had one meeting and it'll continue into November, is really understanding the strategic planning process. And at the end of all of this learning, we'll be able to bring to the executive committee my work plan that I hope to work on for 2020. So, thank you.
I have a question.
Yeah.
I did not see East Valley District on that chart. Is there a reason East Valley hasn't?
Yeah, can you answer? Yeah, I was going to say, Sheila's in here.
Yes, East Valley chooses not to contract with us as the local lead agency, so
Okay.
they do the program themselves. They have about 50 children. No, maybe not, maybe 35, I can double
Okay,
check.
great, thank you.
Yeah, and I should clarify, that is up to the school to decide who they want to work with. Other questions? All right, thank you.
Thank you, Amelia. Dr. Lutz.
There was such a great picture of the district.
Well, good afternoon. I'm going to do things a little bit differently. Typically, I sort of follow a normal order, and this time I'm going to do, since it is maybe Halloween, I thought I'd start off with an other. And as Amelia sort of suggested, what I want to talk about are some of the other things, and again, highlighting nurse-family partnership and the violence video. But I do want to make mention of two things that I find interesting. We had a mobile clinic, we had a mobile dental clinic that was here earlier in the month, and over the course of about 4 to 5 days, we saw 68 individuals of all ages. It was staffed, it was funded by our Cora, which represents the foundation from Delta Dental, and it was staffed by a dentist from OMAC and 6 local dentists who volunteered their time and their services to see 68 individuals. Complete care, anywhere from extractions, x-rays to fillings. And so again, I think it demonstrates once again the outreach efforts that we're trying to do with the local community. So I thought that was of interest. And then I'm also going to talk about a little bit more in my report about the outstanding vaccination efforts we've been doing around hepatitis A. So getting into my other, Ben, last month you talked about End the Violence video, and the importance of, again, acknowledging that and recognizing that as a significant issue in our community. As Amelia mentioned, we had a number of contributions to that program, and we actually have two of the co-stars of the video here, who I would ask to come forward and talk about their role. But to sort of preface that, I want to look at some of the data. First of all, what is domestic violence? And I think, again, if you look at it broadly, it's essentially violence that happens within the home. It's oftentimes conflated with intimate partner violence, but they are somewhat separate because we know that violence occurs at multiple levels. Intimate partner violence certainly has the lion's share, unfortunately, of it, but it can also represent violence against the elderly and violence against children. And we know that as a community, we've identified family violence and addressing its causes and its impacts as a priority. And so again, this I think is really important to recognize that we have a significant issue in our community around violence. And these are some of the data points, which again are very disturbing. They made the newspaper a couple of weeks ago. But we unfortunately have a higher rate than any other county across the state. We have higher rates than the state average. And again, I would sort of rhetorically ask you why. Why is that? What makes our community so problematic or so, again, have this domestic violence happen? And some of it I would, again, fall back on those upstream causes, poverty, low socioeconomic status, low educational attainment. We know these are some of the factors which, unfortunately, are characteristic of our community. And until we really start to address those upstream factors, which is challenging, because again, it really looks at the social fabric of our community. Until we address that, all we are really doing is addressing outcomes and just putting Band-Aids on this constant bleed. And so again, I think that's one of the things that we at the Health District lead. We look at those upstream causes, and with partnership and collaboration, we ask, are we okay with that? And I think we're not. And so how do we then address that as a community? So again, looking at domestic violence, looking at the role that we play, I'm going to ask our two co-stars from the video to come forward and talk about their role in the Nurse-Family Partnership, what their role is and how they work with women who unfortunately oftentimes are experiencing domestic violence.
Thank you, Dr. Bob. I'm Amy Krauss, and I'm one of the nurse home visitors, along with Alicia.
Yep, Alicia Krauss.
And we're one of 8 in our team. We serve clients throughout Spokane County, as was previously mentioned. And Dr. Bob asked us to come and share some stories with you today. But first, a little bit about Nurse-Family Partnership. It's an evidence-based home visiting program, and it was developed in the 70s and has ongoing research. It is primarily for first-time moms. We are participating in a MOLTIP trial, and MOLTIP means momming it again. So they're pregnant again, and they may not have had the opportunity to parent previously, or part of our enrollment criteria for that MOLTIP population is that they have additional risk factors. The common risk factors that we see, unfortunately, are substance use, homelessness, significant mental health. At enrollment, about 67% of our moms self-identify as having symptoms of depression, about 60% of anxiety. And the topic at hand today is about intimate partner violence. But we'd like to highlight how these various challenges interact and make our jobs challenging. And we have some stories today about some rewarding stories as well. Okay, I think we're ready for you.
Okay.
Yeah.
So before I start to share my story, I just want to highlight that our relationship starts when they're pregnant. And so the total time that we're with these moms is about 2.5 years. Early, as we're establishing the relationship, we start to do assessments right away. That's what nurses do. We assess everything. So we do it informally through the conversations that we have with our clients, and then we, through observation, and then we do it more formally through the screenings that Amy mentioned, such as the mental health screens, and we do also an intimate partner violence screen. And that really gives us talking points on how we guide our conversation and what our clients are hoping to get from the program and how we can support them. We talk about, we're screeners, we can't diagnose. So if there is a positive, we talk about who are the people that we can refer or that can work with us, because we're a team, to help support this mom in whatever situation that they're in. A lot of times though, in the beginning, our moms might not disclose intimate partner violence. They're still gaining our trust and they're still learning what they can share and what's safe. So we might not get a positive screen right away, but again, through conversation, it might come out that there is some intimate partner violence occurring. Also, they might not realize that it's not how the media portrays it as the physical violence that we see. There's a lot of power and control and some escalation that occurs in relationships. So I'm going to share about Mary. When I meet Mary, she's been married for just under a year. She's in her 30s, and this is their first child for either of them, and they're really excited for it. Quickly after meeting, we always start to discuss who are your supports? Who are the current people in your life that you can turn to or that you support? And what do your past supports look like? This also includes, what did your childhood look like? And she does disclose significant childhood trauma or adverse childhood experiences and how she spent significant time in the foster care system and that she was eventually adopted by some relatives. Over time, she did have a positive IPV screen in the beginning, and she's a pretty open book. So she starts to share about her relationship with her husband. She shares that he has a significant drinking problem, which has been exacerbated recently when he started day shift. So now he's home in the evenings and his drinking has really picked up. She also shares that in her pregnancy, she's noticed that his monitoring behaviors have really increased. So he'll call her and expect her to answer, even when she's at work. So this interferes with her work and her ability to do her job well. At home, he expects her to pin up all her appointments next to the calendar, and I'll write them on the calendar along with any additional things that she has going on throughout her week and her day. Shortly before baby Jay arrives, she shares that suddenly he's knowing where she's been through the day and who she's been with, and she's not sure how. So there's some even increased tracking going on, either cell phone, car, we're not sure. With the support and resources, we talk about the YWCA, and she does reach out locally on the phone and starts to talk with an advocate. She's not willing to go in because of his monitoring behaviors, but she is having conversations. However, she shared that one time he was home and he'd answered when they had called. They used the guise of calling for an appointment reminder, but again, remember, he's tracking her appointments, so he does become suspicious. Before baby Jay arrives, she's not ready or willing to leave the relationship, and we'll talk about why. So we talk about what can you do currently to keep yourself safe. So she does have a car, she pays her own car insurance. She has her own phone, pays that bill. She has her own bank account. So she has a lot of things that belong individually to her if and when she decides to leave. She has a safe friend that if she needs to flee, she could go to, but he's out of state. So after baby's born, that could be potentially kidnapping if she flees with baby to another state. Her adoptive parents are also out of state. Through the relationship building and discussing supports, she has some family locally, but has shared that they don't have appropriate boundaries, and really if she were to flee there, she doesn't know that they could keep her safe. So at this point, she doesn't feel like she has anywhere long-term that she could go, which is part of the reason she's decided to stay. She has another thing we did with safety planning is talk about collecting important documents. So she's been able to collect things, birth certificates, social security cards, and have her friends store them for her, again, when and if she decides to leave. Those documents are already somewhere else. In her car, she has extra clothes, extra baby stuff, because babies spit up, babies do things. So she's able to communicate that way to her husband. Shortly after baby Jay is born, she really shares that she's concerned about sexual encounters with her husband. He's made comments that he'd like to get her pregnant again soon, which is a tactic often perpetrators will use to keep victims in the relationship longer. So we talk about conversations that she can have with her provider, and she does start Depo-Provera, which is a injection that you receive for birth control and has less ability to be tracked from other birth control options. After baby's born, he expects her to go back to work really quickly. She finds a different job, more consistent hours. However, between his full-time job and her part-time job, she no longer qualifies for Apple Health Insurance. So he can add her, but he refuses. He says it's too expensive. Even if she offers to pay the premium, he's not willing to do it, so she's currently without health insurance, having to pay for that depot and any appointments on her own out of pocket. They also make too much money to qualify for childcare subsidy. So she's forced to find inappropriate childcare, and we have to have a pretty candid conversation about that. We do a lot of problem solving, and she is able to identify a family friend who's been a stay-at-home mom and is safe and appropriate, so that's where baby is currently. She is slowly saving little bits of money when she can, but again, without that long-term safe place, she's not willing to leave. She disclosed that her husband also has untreated and undiagnosed mental health. He recently had a panic attack. He went to the ER. He thought he was having a heart attack. So the conversation has begun with his doctor about that, but thus far he's not willing to seek any treatment or counseling for himself. So this just highlights a lot of the complexity that we're talking about with our moms, and this is just one of many stories. You know, if she does decide to leave, again, she'll be without childcare because she can't keep him where he's at. That wouldn't be safe. She'd probably qualify for the childcare subsidy, but part of, you know, as Dr. Bob had mentioned, with looking at Spokane and our numbers, we're kind of a childcare desert. There's not a lot of infant spots. It could take 6 months or longer to get an infant spot. So in that time, she might be forced to quit her job. TANF is not going to be enough money to afford housing, so then she's going to have housing instability. So it just, again, creates a snowball effect when our moms think about leaving and weighing pros and cons of their risk. But throughout, we also talk about the amazing work that she's doing with her baby, the ways that she keeps her baby safe. She doesn't put him on the floor if dad's been drinking. That's not safe. The way that she is so loving and responsive to that baby and creating such a great bond and attachment and setting the foundations for optimal brain development. And you can see that he's not one that is worried and fearful and scanning. He can really learn and engage and grow. And so we talk about how can you continue to do that as baby grows and develops. So that's my story, and I appreciate you listening. And Amy has a story that she is going to share as well.
Thank you. Thank you. I just wanted to go back to the Nurse-Family Partnership goals overall. I think I skipped over that. That our goals are to improve pregnancy outcomes, to improve child health and development, and to improve economic self-sufficiency. So the relationship is really part of that intervention. And we have all kinds of families who choose to flee domestic violence or remain or are having a cycle of fleeing and returning. So I will share another perspective. I met my client, M, in a home where she was living with an uncle. She had moved here from the west side of the state to flee a domestic violence situation with the father of her baby, with whom she was pregnant, and she had decided that she wanted to support herself, and so she didn't want to seek out WIC or other economic support. So she was working 2 jobs when I met her, and she had very significant mental health with anxiety and depression, but she really wanted to have a healthy baby, and she thought, if I can get away from this person and create a healthy life here, she was open to that, and she was also kind of an open book, and so we were developing that trust and that rapport with her. After she was looking towards having the baby, she was thinking, who's going to watch this baby? I have to go back to work. How can I make this happen? She didn't have a degree, so she wasn't able to have a job where she was able to earn enough money really to provide for childcare. She ended up finding a kind of family friend who was willing to watch this baby. And my client found, that difficulty of single parenting to be very hard and to be working full time as well. So she started to think, well, maybe if I give it a try with the father of this baby and he can move over and we can try to see if this will work. Maybe things will be different this time, hoping for that. And so he did move over, and her life became increasingly complex, and she had, more challenges with the verbal abuse and the power and control. She had to find kind of ways to stay safe, in the midst of this living situation as well. And She had multiple moves. She did seek some support for her mental illness and got on medication. This is kind of more of a rare thing that we see with our families. A lot of them are not kind of willing to seek out that mental health support. But this mom was a wonderful, wonderful parent to her baby, and throughout her kind of decision-making, and as I would come each week or two to talk to her, it was kind of what's unfolding now, what's happening right now. There was a lot of chaos in her life. She did end up leaving again and was able to go to some safe friends across the other side of the state, and she continued in nurse-family partnership and was able to enroll with a nurse in that county. And she got enrolled in college, and she also has her daughter in the on-campus childcare. So she's just really moving forward for her family, and it's just been really gratifying to work with her. We come alongside. We don't, push. We are meeting the clients where they are and preventing that family violence from continuing into further generations. I think you've all been provided with some of the information about our program here in Spokane County, as well as some return on investment, and then there's that domestic violence report as well. So at this time, I believe we're ready to accept questions. Yes?
So my question is, how, and I may have missed this in the beginning, what's the referral process? How are clients referred to you, or how do you connect with them?
We have an evolving referral process, continuous quality improvement. So as of January, we do have a referral coordinator who is working with agencies and community partners, and we do get quite a few. The majority of our referrals come from WIC. We are working at creating those relationships and making NFP known in the community. Some providers are more aware of it than others, but the eligibility for the moms, for the first-time moms, is that they are low income, so they would qualify for Medicaid or WIC. They are in their first or second trimester, so we're enrolling them, the earlier the better, but by the 28th week. And as I mentioned, we also have like about 30 spots for multips, but we keep enrolling them anyway, so we're like at 42 now. Some of the moms who have been in the program, we have a pretty low pregnancy rate again for those moms, but some of them do become pregnant before 2 years, and that's actually on in that blue rectangle on that page as well. So the next, did that answer your question?
It did, thank you.
Mm-hmm.
So, do I need to speak in here?
Go ahead.
Okay. So, my question is about jobs. Do you help them get jobs? Because I heard you say she didn't have a college degree. And then this woman you helped get into college. But I'm wondering about working with the trades, because we have such a shortage in welders and carpenters, and so kind of a two-part, jobs and what kind of jobs?
Do you want to answer that one?
Sure. Yeah, we do. So we assess throughout the program what their goals are. Generally in pregnancy, it's really focused on healthy pregnancy and that baby. But then 4 to 6 months after, we really turn back on mom and what her goals were, either prior to being pregnant or now that she has a little one to support. So if it's not school, and sometimes it's not, we look at what is the highest level of education you've obtained. So if they have not obtained a GED or a diploma, sometimes we can support them in getting enrolled in a GED program or the high school completion programs that we have in town. And so we really work with them also not on just getting in a program, but what program is going to work for you. And then if they're not somebody that wants to be college bound, then we do look at where do you feel your strengths are? What would you like out of a career? What have you done in the past, and did that work for you, or are you looking for something else? I'm not sure as far as the trades that you spoke of, but I do have a significant number that want to do like a certification program, a medical assisting, other year-long 15-month programs. where it is more of the trade aspect versus having to go back to school for 2, 4, or longer years. So yeah, we do address, is it school, is it work, is it career, what are they looking for now? And it might be, I just need to get a part-time job, and then I'm gonna focus on getting into school or getting into a more career job. So we look at that. And
I just know there's a lot of opportunity right now with the trades, and they pay really high wages, often more than you would make in a college-driven type career. If anyone's had a plumber come to your house lately.
Yes.
You know, so I'm just saying, you know, working with those businesses, I think they're eager to find any new partnerships they can find to grow their workforce.
Thank you.
Yeah,
So,
that's a
and
good
women
perspective.
can do really great jobs on a lot of the trades, so, great. I mean, on all of them, but I'm just saying there's some specialties that, you know.
Yeah,
that
and
are
I
good.
think our manager Sue's gonna weigh in on that as well.
I just wanted to add one additional thing on Sue, I'm the program manager for the next family partnership. In the little blue box, one of the details that school department outcome perspective was the amount of.
Can we actually have you come up to the microphone too, so we get it? Sorry.
You want me to go up there?
Yeah, if you don't mind.
Sorry.
It's okay. Just trying to keep us on the record.
Okay. Thank you. Sorry, I didn't mean to interrupt.
No.
That's
The more the merrier.
Okay, as I'd mentioned, I'm Sue Schultz, and I'm the program manager for the Nurse Family Partnership Program. And on this sheet that was distributed with your packets in the little square box, one of the indicators that I pulled up that really looks at the success of the program is workforce participation, and we look at whether or not they're, you know, we look at their level of education, we look at whether or not they're working at the time that they enter the program, and then we reevaluate that, because one of the primary goals of this program is self-efficacy. We want to, in order to maximize the return on investment, thank you. We really want to get these young women back to work in school, being successful and able to move forward with their lives. So the most recent data that I had, that 17 or younger, only 20% of those young women were working, and at the time of graduation that it increased up to 53.7%. And that does not include those that are still in school and you know, moving forward. So that's a huge increase. A lot of those young women within 2 years, by the time they're 19 years of age, are entering the workforce and successfully supporting their families. If they're older than 18, there's still an increase. It's not quite as significant. And the question that was asked to me was, well, why do you think that is? And I think it's because they've been in the system longer, and I think it takes a little longer to move them up and out of that system and what the normal is for them. But the work that these nurses do is amazing. They're making big changes on a daily basis with these families, and you know, we're changing communities one family at a time. And I have done this job for 10 years, and I'm amazed on a daily basis with the complexity of the clients that they're serving, all of the risk factors that these families have, but yet these nurses are able to meet them where they're at, develop relationships, and walk beside them to a successful outcome. And it's pretty amazing to see. The only other additional thing, and then I'll step away and let you guys continue, is we just received notice that we have been funded for expansion, and so we will be adding some additional, our ability to serve an additional 50 families, and they will be focused in the Spokane Public School District, because that has been identified by the state home visiting services account, or it's as the highest risk area in the state of Washington with regard to outcomes. And so all clients that we will be enrolling to that funding stream will come from that from those zip codes associated with the Spokane Public Schools. Other communities will still continue to be served, but they will be filled into other spots. Questions?
So would you add to the information about referrals, our work particularly with our treatment services program?
Mm-hmm. Okay, sure. We have a lot of referrals coming into our program. We currently have a waiting list of 27 women on that waiting list, and we're only able to enroll them as they have ability, openings in their caseload, and I'm very familiar with the kind of clients that they're carrying, and they get new enrollments based upon really what's happening with their current caseload and really what is the acuity of some of those clients. So we do have 27 families that are waiting. Some of them are women who have had previous babies. Others are first-time moms. And we reach out to those women and schedule appointments and things to get them enrolled in the program. One of our biggest challenges is that many of the families that we're seeing these days have lots and lots of risk factors, and so connecting with those families becomes even more challenging. So they'll come in to a provider, and a provider will refer them to our program. They complete the documentation to allow us to contact them, but then their phone is disconnected, and most of them don't have a residence or an address. So trying to locate them and get them enrolled in the program is an ongoing challenge, and it takes a lot of effort to try to track some of these families down. We receive referrals from our WIC clinic. We have medical providers throughout the community that refer to us. We have a relationship with our opioid treatment program, and we've added some support staff. We have an opioid case management person now working with us. She has a program that's called You're Not Alone, and so what we're trying to do is wrap those pregnant substance-using women with services and have an individual who can walk beside them to get them into treatment and to have a healthy baby and have the opportunity to parent. So there's lots of things happening within the agency looking at the families, maternal morbidity, mortality, parenting. It's just really exciting to see. Questions?
I had the opportunity to go out with one of the nurses, and I was really impressed. And you could see the need, and then you can also see how she could measure the outcomes, and then the relationship that was developed, and the long term. And in the family that I was with a couple, one of them, the dad was involved too, and so she was teaching this whole family and kind of changing the whole. And so I was really impressed with that. But what I was curious about, when you said there was a waiting list and you have more funding, but where, I'm looking at this, it says the cost savings, and I know upfront costs, because it's one-on-one, are expensive, and you're always having to try to prove why, long-term. And where in the pie does this sit in how much funding goes to that program versus other programs, and how do you show the long-term results of this, because they're so, early childhood intervention is so important to break that cycle. And
Nurse-family partnership is the gold standard as far as evidence-based home visiting. There's lots of home visiting programs, but this is the one program that has over 30 years, almost 40 years now, of data to support those outcomes. So Dr. David Olds, who is the founder of this program, has been able to follow families for many, many years, and so we're able to demonstrate these specific outcomes. So we have these immediate outcomes that I've listed here, but the studies, and I have lots of information I'd be happy to share if anybody has any interest in that, but the studies are showing that this impact continues beyond the toddler years for those families, that there's a 40% reduction in child abuse and neglect in families that have been involved in the Nurse-Family Partnership Program. There's a huge decline in access of Medicaid and other services for families that access the program. So some of the most recent literature, I was just at a meeting with Dr. Olds, and they're now being able to demonstrate that participation in Nurse-Family Partnership has allows for a decrease in maternal morbidity and infant mortality, but it also has an impact on chronic disease development. And you kind of think about all of those adverse risk factors, all of those instances of trauma that we're protecting these children from. They're not hopefully going to develop so many of those chronic diseases associated with adverse childhood experiences, because they're being raised in an environment that is so different from the environment that their parents were raised in.
so where does that sit in the pie for funding? I'm sorry.
Within the agency?
Yeah, for funding for this program compared to the rest of the funding.
Okay, so our program is funded through a combination of federal dollars, state dollars, and a small amount of local dollar, which is funding through the health district. So currently, our funding, we have about $800,000 that comes indirectly through the state, through the federal McV funding stream, which is maternal, infant, early childhood home visiting dollars. So about 800,000 comes into us. Those are considered federal dollars. We have some DSHS funds that are coming to us specifically targeted for TANF families, so women who go in to apply for temporary assistance for needy families. If they're identified as having significant risk factors, they're referred to us, and they have the ability to say, I'm going to mandate that you participate with some sort of a parenting program, and Nurse Family Partnership is one of those programs, and they'll send us a referral. And so that's a second funding stream. And so we have about almost $130,000 that we are able to use for covering that group of clients. And so that basically covers the cost of one nurse. And then we have just received the expansion funding, which will be an additional I think it's $215,000 the first year, and then it's $290,000 a year beyond that, and it's renewable each and every year. And so that will allow us to add some additional staff. We do have 2 positions that are funded through local dollar. So out of 8 nurses, I have 2 nurse home visitors that their wages and expenses are covered by health district funding. And it usually averages between $200,000 and $300,000 with regard to our direct input into that program. Because we received the expansion funding, I just learned yesterday that we also will be receiving additional funding from what's called an incentive fund from the Nurse Family Partnership National Service Organization. So that'll be an additional $100,000 of matching funds. They'll match our expansion funds for 3 years. So we'll be able to offset, I think, even more of our local dollar expense, serve more families, be able to increase our additional nurse supervisor. In order for us to expand, I have to add some additional management staff, and so they're going to help offset the cost of that. So I'm thinking, we're going to continue to grow. We have a huge need in our community. We just had the Washington State Nurse Consultant here today and talked about the complexity of the clients that we're dealing with, and I think we have one of the best NFP programs in the state, and she will be one of the first to admit that that is indeed the case. Our outcomes are consistently good. We're doing a great job with these families, and I feel really honored to work with them. Anything else?
One more question.
Oh, wait, that's okay.
Sorry.
Yay, good job.
So where do you see goals in the future? What would you like to see with the Nurse Partnership Program, down the road, if there was more funding?
I would like to see us to be able to continue to expand. I think that we have, the most recent data showed that only about 4% of eligible families in Spokane County are currently receiving home visiting services. So that tells you that there's a lot of other families out there. I think in last year there was a little over 5,000 Medicaid births per year, something like that. So that would be the low income criteria. And because we can enroll both first time and repeat parents, I think there's a very large pool of families that we can pull from. It's having the capacity to enroll. It is making sure that we can recruit highly trained staff that can fill those positions. Underserved areas, I think, are the Native American communities. I think that there's underserved areas with the African American communities as well, trying to get some more services into those communities. In the city of Seattle, I think they have 3 teams of 8 nurses working within, that Seattle proper. And I think at a minimum, it would be nice for us to have 2 full teams of 8 nurses, which would be 16 nurses, which would, we could get up to serving 400 to 500 families that way a year.
I'm sorry.
That's
to get more
okay.
time, but is there I know you refer to different partners like the YWCA, you said. Is there a group or community centers, or is there anywhere, that each community has a little center for 0 through 5, that age group? Do you understand what I'm trying to say?
There's lots of I mean, there's lots of resources out there. You guys are probably more familiar with that specifically. You know, I think that our ability to network and interact with these families on a community level is really important. And I think that it takes a program that is classified as an expensive individual service-based plan into one that is much more of a community-based plan, our community-based service, because that's really what we're doing. And it's one of the few programs, and I have, again, lots of literature to demonstrate that really can make lifelong changes in the lives of these families. And it's, you know, having the capacity to enroll more, by having that capacity, we're able to increase our reach, and we're able to make more change to more families, which will have a positive impact on the community.
You know, one of the things that I say when people tell me how expensive this program is, and for 2.5 years.
If we could get you to come up to the mic so we
It's
have.
about $6,000. If we serve the family for 2.5 years, our cost is about $6,500 for that family, which is real money. But I also talk about what an average year of public education costs. So we're at about another year of public education for this family to get to the outcomes that are demonstrated. And the other services are not getting us to those outcomes. We're all trying, lots of people are trying. So I look at it as an investment of our dollars.
I was just going to say, with prevention dollars, substance misuse and violence prevention, we know that every dollar invested in prevention can save up $14 to $21 on the other end in justice systems and everything else. And this is the primo prevention program for infants. I mean, I've been in the legislature at hearings and heard this program just praised by legislators and saying this is where we need to start. So, I mean, I think it's a fabulous program.
Thank you.
And our kids deserve it.
And we'd be happy to have anybody join us on a home visit. You can contact Sue and we'll get our calendars matched up, so yes.
Make this short. Is there anything out there for homeless women who are pregnant with or without a spouse or a boyfriend or a partner? And the reason I ask this is that I came into contact with a young woman who was homeless, who was pregnant with a boyfriend, and they were running all over just trying to find a place to be safe. And I didn't know where to send them. I didn't know the first thing to do to help them. So I'm just wondering, is there any kind of resources or outreach to those clients?
Yeah, a number of years ago, we moved to a homeless coordinated system of entry. And so we do have like a physical address and a phone number where that woman could go to start that application for, and also have resources for where to stay that night, you know, that week, that kind of thing. So as I'm sure you're well aware, you know, there is a dearth of affordable housing here, but we could give you some of those flyers that have places for meals, and there are a number of different agencies, mostly you know, private nonprofits that have houses or
Right.
communities for homeless families, you know, and so they each have a little bit different criteria, and it might be that the partner could come and stay or not. Yeah, go ahead.
As mentioned, recently we have partnered more with Catholic Charities program to house those women who are pregnant families. And so our staff have been meeting with them and referring those type of people. So they have a special community health worker for that. So
Perfect, thank you.
they can get to you.
Poor girls aren't going to get.
15 minutes.
They gave a chance to finish their.
This is about
You know, and the other thing too is, it's okay to refer those families to our case management people here in the health district, because we can wrap them with services and get them someplace and have somebody that can walk beside them and get them the help that they need. So they may not be eligible for NFP, but we will assist them, we'll make referrals, we'll get them to the places that they need to be. And so feel free to give one of us a call, let us know, encourage them to come up and stop by our office, and we'd be more than happy to help them.
Great, thank you.
Okay, thank you.
Thank you.
Did you girls, were you able to finish your lecture?
Yes.
Okay, I wanted to hear the ending of what you had to say. If you finished, well, that's okay.
Yep,
All
we're
right.
finished. Thank you so much.
All right, good job.
Oops. It's funny, when we were talking about this presentation, Sue said, no, I don't want to come up. No, I mean, just let Amy and Alicia talk about it. And then Bob, I'd ask you a couple things to say at the end. And it's like, no, you just did fine, Sue. Thank you. Thank you, Sue. Thank you, Amy. Thank you, Alicia. Thank you, Sheila. So obviously, over the last couple months, I've been talking about hepatitis A. And this continues to be an issue that we're dealing with. I would like to say, actually, this is now current, because as of earlier this morning, we had 51 cases. We now have 53 cases. They continue to rise. 23 cases at the last time I presented to you a month ago, and we've more than doubled. And again, our significant concern is, as cold weather approaches and we get individuals living in sheltered environments, that unless we really aggressively address this, as we've been doing, these numbers will continue to escalate. So what have we been doing? Yes, Kylie is here. Kylie has been leading some of our vaccination efforts, and again, these numbers are just incredible. Since the outbreak began a couple of months ago, we've done 66 clinics, and oftentimes it's 3 and 4 people. It's not like we're doing huge numbers. Oftentimes it's a handful of individuals. Just the other day, for example, she and Kira, who's sitting in the back, went out with some outreach workers from SNAP, from other organizations, and they went into encampments. And they found 7 individuals. Is it 7 or 8? I'm not sure. We keep on, 7 or 8. But bottom line is, they found individuals who were amenable and, again, needing vaccines for hepatitis A. And so again, for me, these numbers, I mean, just in the couple of weeks we've done this, 2 weeks ago we had a jail vaccine blitz. And over the course of one day in the jail across the street, we vaccinated 500 individuals and some staff members. So again, I think this just demonstrates the effort that we're doing, but again, it's not just us, it's working with partners, and this really needs to be a collaboration. Because again, we can only do so much, but without the partnership and the other organizations helping us, this outbreak will be a very slow burn. And that's unfortunately what we've continued to see. So per request in your handouts, there's a document that kind of gives you a little bit of a national perspective and what's happening at both the state and the local. So the other issue that I talked about last, and is something that the Washington State Board of Health weighed in on a couple of weeks ago based upon an executive order that came from the governor, was about what we are now calling, in medicine we love acronyms, and so now it's being referred to as e-cigarette or vaping product-associated lung injury, or EVALI. It just sort of rolls off the tongue. And as of last week, these are the number of cases nationally. In the state, we've had 12 cases. But you can see, again, the magnitude of this issue. What we're also seeing from the epidemiology is that there seems to have been a significant peak that occurred a couple of weeks ago, and the numbers are tapering off. I would suggest to you that some of that is the simple fact that people are becoming more aware of the fact that vaping is not safe. We still do not know exactly the causative agent, what is causing these people to have a constellation of respiratory problems that are a variety of different pathologies that we're seeing at the microscopic level. So again, of great concern that then was combined with the issue of teenage vaping. We know that vaping, unfortunately, is disproportionately found in young people. The numbers are really impressive when you look at the fact that more than almost 21% of teenagers in 2018 reported to regularly vaping, and yet only a couple of percent, 3% of adults said they regularly vaped. So although it's been argued that this is a means to cease tobacco usage, we're not finding it to be such. And the reality is that we're now finding kids much more turning to vaping, oftentimes not knowing that there's nicotine and not realizing how addictive nicotine is. So we talk about heroin, we talk about other addictive substances, let's talk about nicotine and its incredible addictive potential. So unfortunately, what the tobacco industry and by proxy the e-cigarette industry is creating is another generation of tobacco users. So as a result of this, it represented an intersection of both this national crisis of teenage vaping and this health-related issue, which then prompted the governor to put out an executive order, which the State Board of Health weighed in on. And this is, again, what occurred on October the 9th. I unfortunately was not able to make that meeting. I and a colleague were stuck at the Spokane airport. That occurred the day of the snowstorm, and the airport was not ready for it. But I was able to participate from a distance. And I will tell you that more than 60 people gave testimony. There were more than 200 people who showed up, and it was very civil to start off with, and then became more heated as the testimony began and continued, to the point that there were actually, at times, maybe cause for calling in guards. Then when the actual information was presented, there was again a lot of outcry and a lot of interruptions. And it was unfortunate because, again, I think what began as a very civil conversation escalated. Bottom line, State Board of Health weighed in. We voted unanimously to enact a 120-day legislative hold. And where it sits right now is that this hold is in place, albeit there was an attempt to file a temporary restraining order that was issued last week in the Thurston County Superior Court by the Vapor Technology Association and Barron Enterprises. It's a national organization that also was successful at allowing the ban that took place in Oregon to be put on hold. And so the judge essentially said, I'm not ready to decide on this temporary restraining order. And so he has called for a filing and a hearing on the 8th of November. The three issues that were, again, suggested in the motion were that it exceeds the authority of the State Board of Health, it's arbitrary and capricious, and it's restricting on offering flavored vaping products for sale violates constitutional free speech rights. The judge threw out the last two and said he will weigh in on whether or not it exceeds the authority of the State Board of Health. So this is what's pending in front of the judge, Superior Court Judge Chris Lanise, on the 8th of November, so stay tuned. But in the meantime, it's still in place. I will tell you that it's a little bit concerning when I drive by some vaping shops. They're required to put signage in obvious places, but the obvious place can be inside. And that's what I've seen in a number of situations. I was down in Stoughton earlier in the week, and there were two cannabis shops, both wide open. They're not selling flavored vaping products because they're also required not to, but there was no visible signage. So. Any questions?
I just want to go back for a second to the hepatitis A. What is happening with sanitation? Is there anything being done for sanitation for the homeless? And
Yeah, I
the
think
issues that we have?
I think that's a very good question, Andy. Thank you. That's been one of our outreach efforts and recommendations. So, for example, one of the things we've been working with in our environmental public health group is working with, for example, restaurants and feeding sites on how you provide proper sanitation, how food should be handled and things of that sort. It does, as I've emphasized before, hepatitis A is not a virus, it's not an infection of the homeless or individuals who use substances. It's an infection of sanitation that's amplified by the conditions in which people are living. And so I think the more that we can do as a community to provide those sanitation facilities. Again, great concern as people who have been living outdoors come indoors. How do we really enhance those opportunities for, again, good sanitation efforts? So it really, again, is us encouraging and working very closely with our partners and with the city to make sure that that happens.
I was just going to note in furtherance of that, Dr. Lutz did present to City Council it was just Monday night, I think, on those issues with making strong recommendations for city providing sanitation and shelter and things like that. And I don't know if it was just that presentation, but we had one warming center where there was no running water sanitation, just porta potties, and the city's now spending the money to put bathrooms and showers in that place, which is a huge improvement. But it's the health district's job to tell us that we need to do that for health reasons, and then it's the city's job within the city to actually provide it. So it's a great question.
Good, thank you.
All right, thank you, Dr. Lutz. Now we're up for our legislative report.
Pardon my ears. I pinky promised a 3-year-old I wouldn't take them off, and I take pinky promises very seriously. I also have quite a cold, so excuse my nasally voice. Okay. Oh, great. So just to remind you of our process for the legislative agenda, first, what I've done is collaborated with other agencies, with WSALFO, with other health districts across the state to understand what are some cross-cutting priorities that are coming up across our state. And then through our strategic planning process, SRHD identified strategic priorities. Early in October, which is earlier this month, we worked to begin our mapping the systems and started to understand some of the upstream, midstream, and downstream factors that affect family violence and trauma and behavioral health outcomes. Then I met with the Board of Health Policy Committee, and we prioritized some issues, which I will talk about more in a minute. And the next step is where we are today to present those priorities to all of you for consideration. Throughout November and December and the legislative session, I'll be participating in various committees to identify and track specific pieces of legislation that are relevant to these policy issues and keep you updated as the session goes along. And then in December, an action item will be to actually accept a resolution around our legislative agenda. So this is what we did with the policy committee. I had 2 cross-cutting issues, 9 themes that came out of our systems mapping work, and then 4 upstream issues relevant to our 3rd priority area of cardiovascular disease. And through a focused conversation with the committee, we identified 4 priority areas for consideration. And those priority areas are as follows: foundational public health services funding, preventing and reducing the impact of adverse childhood experiences, or ACEs, substance misuse prevention and treatment, and access to care. And I'm going to go through each of those in a little bit more detail, but keeping this fairly high level for today. So first is foundational public health services funding. Just for background, what is this even? Years ago, the National Academy of Medicine called for a minimum package of public health elements that need to be available in every community so that public health can be practiced equitably in all people, regardless of whether you're in a rural community or a large urban community. 2019 was a fairly good year for foundational public health services. In our state, the budget passed $22 million for foundational public health services funding, but it's estimated that it'll cost $450 million per biennium to actually carry these services out in all of our communities. So it's just a small piece that was funded. And here's just a snapshot of where foundational public health services funding goes in our agency. For locally, we get $277,000 annually. That goes towards STD investigations and immunization outreach. And that's still, there's even our STD investigators there's one who's unable to even address all of the local STDs that could be addressed. So there's still a great need for local foundational public health services funding. And then we also do some regional support. We received money to help some of our more rural counties in the region work on We have a staff person in the data center who helps them with their community health assessments and their community health improvement plans. We do capacity building and provide backup for communicable disease epidemiology. And then there's travel for us to go out to those communities. So this is really vital work that is required of every community deserves to have as far as public health services go. And so the ask here will be to just support continued funding for those capabilities, so that we can equitably serve all of our populations. You heard a bit today about how important adverse childhood experiences are in one's life course. Adverse childhood experiences are linked to risky health behaviors like alcohol and drug use, unsafe sex, chronic health conditions like cancer and diabetes, low life potential, so things like educational outcomes, occupation and lifetime income, and early death. So by intervening upstream to prevent and reduce the impact of ACEs, we can help all of the folks in our community. Some policy examples are, you heard about the infant toddler network, our home visiting services that we provide, efforts to support family economic security. And we also have you've heard about our policy Handle with Care that Jen Hansen is working on. So we have things locally, but then there's a need at the state level to do some more. Substance misuse prevention and treatment. We passed in 2019 a new law changing the legal age for tobacco and vaping to 21. You also heard about some of the issues going around on vaping from Dr. Letts. So there will be efforts needed to help folks who are between 18 and 20 reduce their use of tobacco and vaping products since it won't be legal anymore. And then furthermore to improve mental health and substance misuse, the system, and then availability of care, addressing the state opioid response plan, and then addressing this issue of preemption, which keeps us from taking further actions because we're limited by what we can do at the state level. Lastly, access to care. Rates of uninsured in our county and in the country have gone down dramatically in the last decade as a result of the Affordable Care Act, but there are still gaps in our community, and we still have 2% of our children in our county who are uninsured, which is unacceptable. And so policies to support access to care will be around affordability of health care, issues around surprise billing, out-of-pocket expenses, and issues like that. So now I have presented the draft policies to you, draft priorities to you. So next, I just want to flag for you that this will be on the December agenda for an action item. We can talk more about that as we go. We also have a meeting of the policy committee in November where we will flesh this out a little bit more. If you have questions, I'm happy to try to field some of those now. I can't promise that my answers will be coherent. I'm on so much cold medicine. But I'm happy to take some questions. I would also direct you to the policy committee with your questions. And also just want to flag for you that the State Board of Health meeting is taking place in Spokane on November 18th. It's a public meeting. It'll be held at the Davenport from noon to 3. So in case that's something that you'd like to put on your agenda, you're welcome to come to that. Bob.
I would say it's actually, it starts between 9 and 9:30.
Oh, thank you.
And probably goes until about 3.
Questions?
Yeah, I have a question about the foundational public health services. Is that asking for funding, is that for the remainder that was allotted, the 60 million, or is that just for an allotment for part of the 60 million?
The state passed a 22 million, ongoing $22 million, but the need is 450 million. So the ask is to continue funding it and then to fill that gap. Some of our foundational public health services funding also comes from a tax on vapor products. And so there's concern that the new vapor product ban will actually reduce the funding that we receive for these essential services.
So I just have some input on that project, the Foundational Public Health Service Project, because it just got me thinking, because I'm a big proponent of transparency. And I mean, that kind of goes across the board for all our projects for in the public health. But what I was seeing is that the oversight and accountability concerning funding that happens with funding. It's very thorough. But I don't see that with data and how the data is interpreted. And the tracking of performance is evaluated with a lot of data. And this program, this project is a lot about modernization. And there's talk of the public health department actually being the chief health strategist in the community, not an individual, but the public health department, and kind of getting away from direct clinical care, but more towards policy making. So it just kind of underlines the importance of transparency. And I think as part of modernizing this whole thing that we should maybe relook at how data is interpreted and that there's some kind of mechanism of accountability on what is put out there with that data, so that, especially when there's funding is tight, that the interpretation is correct and that it's actually representing or reflecting what's actually going on and occurring on the ground. And so I just think there should be more accountability and kind of an ethical expectation when it comes to supporting funding, if that makes any sense.
I think that aligns with the reasoning behind the foundational public health services, that when the National Academy of Medicine called for this set of foundational services, it came from a place of knowing that there's a lack of funding and that healthcare costs are increasing and increasing and increasing and out of control. And so it's from a need to make sure that we're using our funding wisely. And fortunately, when communities have this funding, that they might have that capacity to handle their data and do evaluation appropriately.
Yeah, I just don't find there's any method for really a mechanism of accountability when data is put out that doesn't reflect what's happening, and it's a misrepresentation.
I'd love to talk more about where you think that maybe data are being mishandled, and I know we're trying to connect one-on-one, so you can follow up with that. Anything else?
I do.
Questions? Yes.
Yeah, so this is just general, and I don't know how much the policy committee's been meeting, but my sense for the agenda, for me, just personally, really want to be tied to specific bills. So just statements of areas isn't particularly helpful for me. I think we need to, if we're gonna do ACEs, we should find what are the top bills on ACEs that are likely to have support and figure out which one. So that really, other than the Foundation of Public Health, which there is a bill on that, I think we need to, if we're gonna have it written as our priority, it should be tied to something. Otherwise, it's really just our strategic plan, which is good, but it's not the same. And the other thing I would like to see in a higher tier is housing money from the state. That's certainly a priority for City of Spokane. I don't know if City of Spokane Valley, I'm imagining it is in the county, but just we are so slammed with that that there's some bills. And I don't know, county, do you have your legislative agenda yet?
We are in the process of developing. We've discussed key categories. Our PIO is compiling sort of the kind of fancy, good-looking sheet with them all listed on there. But
Okay.
So the process has started. We've met with the county lobbyist and all that, but it's still in draft form at this point.
So we just passed ours on Monday, and I don't know, City of Spokane Valley, if you have yours yet, but what I would love, I'm less interested in what the other state agencies are doing on this and more interested in aligning our jurisdictions with the health district thing so that we can regionally go and say, hey, this is there. So that's the other mapping and cross-cutting that I would like to see, and I think the county is pretty close. I don't know if you guys are planning on doing it.
I know we've started our discussions, had a first or a second draft of our legislative report or kind of platform, but haven't adopted anything yet. But we really don't have anything really on there that's kind of public health or any of these topics.
So, anyway, so that's what I'm looking more for before I would be comfortable voting to pass it.
I appreciate that. And this is modeled after our former legislative agendas. I don't know that the 2019 version is in your packets, but it's always been issue-based, not bill-based, but I'm really looking forward to going to these committees throughout November to identify those specific bills, and so I will get them in here for you.
So the last 2 years, we had a format. That's what I would be thinking we were going that format as opposed, you said, what format was this from?
The
Did you say?
2019 legislative agenda, last year's.
Yeah, so
But I thought we had bills for them, we didn't, by the end of it?
Go ahead, Linda. real
What we
quick.
did is the reports started to come in, and as we looked at the agendas, I mean, right now, this was the work of the policy committee to get down to these focused areas with this, and then we'll be looking at the bills, because we know which ones are going to come back from last session, and then aligning, or maybe not aligning, but looking at other jurisdictions as well as places like the Washington Association for Substance Abuse and Violence Prevention, because we, through WASAP, have a lobbyist that worked 100 bills last year that aligned very closely with all this. And so I think we'll get there.
So just my kind of 2 cents on it. I think from this, I'd rather have our definitive ask of what we're asking them to do. I don't know necessarily picking the bill numbers because bills change just so quickly, but having what's the important piece that we want incorporated into whatever legislation that passes. I like kind of your charts that you show on the screen there where it kind of says, here's the impact to us. So it kind of tells that story. Here's what we're trying to do with these dollars, why we want more dollars, and our ask is to increase the dollars by whatever or whichever one of these issues is, to kind of have the ask and then why. But that's my 2 cents.
And I support that. I just, in getting to the bill number level, that just is a really specific ask. So that's, because I just think the legislators, we're going to be meeting with them, and they're going to be like, oh, of course, everyone's for all of these things, but what is the one that you really want us to dig in on? So that's the, because who could be, well, maybe somebody's against these things, but that's good.
Go ahead, Josh.
Well, I think so. This being the second year in the biennium, I think a lot of those bills were dropped, and if I remember correctly, I think the last legislative session, as far as health districts go, were pretty successful on policy-driven legislation. Correct? I mean, so a lot of the things that we that was supported by this body last session actually did pass. So some of these things, I mean, I think and I think Kate, if you want to speak to this too, like when we're going back and talking about sort of misuse of vaping and tobacco, usually when you come back with something that quickly after a major change in legislation with the Tobacco 21, unfortunately, lots of times there doesn't tend to be a lot of desire to reopen something because the mindset is we fixed that last year.
Mm-hmm.
That's done. It's taken care of. So there is that sort of education piece that's going to have to kind of come along with that, and I hope the state association follows up those types of things. Like you raised the age, but that didn't totally fix the problem of what could still exist out there. But unfortunately, with our meetings falling kind of near the end of the month, I mean, I would recommend at our January meeting, if it was earlier in the month, then by that time being a 60-day session, a lot of bills will have been introduced by that point. And at that, ideally January would be the time to sort of pick, okay, these are the actual bills we want to support, take a vote on that. But with our meetings being sort of at the end of January, by that time, I mean, you're 3 weeks into session, and in a 60-day session, that is pretty late in the game. So
I just kind of want to add that our next meeting is December 5th, so hopefully we'll have approval of this, because I think the target was to try and get.
No, correct. But with the legislative session starting in January, a lot of those bills don't get dropped until sometimes a few days before the actual legislative session starts. Sort of in that January 1st to January 12th sort of time frame, and there is when a lot of bills are dropped. There will be bills that are pre-filed. So yeah, maybe if we could each sort of take a look at that before our December meeting and sort of see if there are any public health bills that are dropped, but also go back and sort of look at what bills were we tracking last year that didn't pass, and sort of see what came of those. Did they get out of at least one chamber? Did they make it into the opposite chamber? And sort of what the deal was with those.
I was just going to say, I think it is our intent to put bills on there. This was the framework behind the issues we wanted to focus on and drive our conversation around. And then, as has been mentioned, because it's the second year of the biennium, then we'll have bills from last year we can go back and add. And then, of course, new ones that will drop. And we can totally change our meeting too, to be more relevant to what's happening in Olympia, to maybe the first couple weeks of January, so that we have a better, frame of reference of what's been dropped and everything, so.
Yeah, and I think really I was talking about those as you meant, those bills that were dropped last year that made it through a house or the thing that, and figuring out which of those are the ones. So that's what I'm imagining. So sounds like you guys are doing it and look forward to it.
Any more questions? Great, thank you.
Thank you. And financial report, I think we've kind of covered a lot of it already.
Haven't done well, but thank you.
And then that brings us up to our agenda item for executive session. So do we need to still do that? How? About 10 minutes. All right, we'll call the meeting back to order at, is it 2:24? And all the way up to our board member check-in. Karen, do you have anything you want for check-in?
I have absolutely nothing going on in my library.
No? No joke or anything for us today? Oh, okay, here we go.
So let's go around and then I'll tell the joke at the end.
Oh, okay.
Because I have a few papers.
John?
I'm fine.
So I went to this mapping strategies or strategic mapping project. It was great, whatever it was called. No, it was about mapping priorities and strategies. And room full of people, really good discussions, and lots of rich conversation. And I really just thought that board members should have the chance to have known that. I don't know if y'all knew it was happening. I was invited because of my work through Greater Spokane Substance Abuse Council. But I just want to say again, I think there's some ACEs training coming up. I would just like to ask that somehow the board get notified of anything that's happening so we could choose to come if it's something. Because I think it really helps us to be informed on how to do this public policy work, the discussion work. And so I'm just, again, I asked last time when we had, I think it was food inspection, something was changing with that. And there was a webinar the day before that I thought, oh, if I'd known that, I would have watched that and been able to talk to the hospitality industry person in a better way before the meeting. So just asking that we do that, because it is really good, rich work that's being done, and I'd like to just have the opportunity when I can to come to trainings.
Josh? No, the only thing on my thing is just to say thank you to Dr. Lutz. I know we talked about the hepatitis A kind of outbreak and getting us some information to give to our council as well, and so there was a press release issued, so appreciate that, and appreciate the handouts here today so we can kind of share that with our council too, so
Yeah.
thank you.
Again, it wasn't me, it was actually our epidemiology staff who put that document together, so.
Well, exactly. And I don't see any other citizen input, so the next
Ben,
meeting.
I did have one more
What?
thing. We had a town hall on underage drinking, vaping, and marijuana use, which was funded just $750 from the SAMHSA, Substance Abuse Mental Health Services Administration. And Joel, in his new position, you had his picture up there for fall prevention, but he came out as the vaping expert and just was incredibly good. I was so happy for him representing the health district. And then we had law enforcement, Chris Johnson from Spokane Valley Police and Sheriff's Office, and Heather Lemery from Native Project. And then our Spokane Valley Youth Voice actually had the youth perspective, and it was really, really good. But people are very concerned about the vaping, and I think there's heightened awareness to help us in our work to prevent our young kids. So I just wanted to shout out for Joel.
All right, with that, our next Board of Health meeting is December 5th. Thank you, everybody.